Yes. And remember, this system, we've talked about how we've used it for our total online digital triage. If you do triage in other ways, telephone, and other ways, you can still use it to run a green list of people and conditions that are okay to wait until the next routine appointment. Use it, keep your practice safe for your patients because nobody else is looking out for us. We need to
Oh,
look
that's
after
a bit.
ourselves. It's the truth. Who is looking out for us? Tell me. I've not been impressed last
You're
night.
not allowed to say anything during PERDA, apparently. Apparently, we're not supposed to have opinions during PERDA.
I wish somebody would understand the problems we face and do something about it. You know, like a.
Do you feel a rant coming on? Yeah. Okay. Hi, everyone. We are back. We've just been to the BMA Roadshow.
And that's made us think and talk about a lot of things.
Yeah. So the primary aim for today is to show people how to run a waiting list safely in primary care. We've not done it lightly. I mean, we've been running a waiting list for quite some time and prioritising according to clinical need. But, well, let's just set some of the context and then we'll actually go into the mechanics of how to do it. So why are we doing this? Pray.
So I think the roadshow is quite good in this regard, and it talks about like some of the pressures that we're all feeling. So this is stuff we all know. So 91% of consultations take place within primary care, but we've got less and less of the budget. It's now dropped to 6%. We know that seeing a GP is much cheaper. That's £42 on average, and it's 367 for one ambulance call out. An A&E appointment is £86 to 418, so way cheaper than those. And as you'll know, Pharmacy First get £80 for the UTI.
And they still come back and see the doctor.
Yeah.
So,
Yeah.
and those are sources from the King's Fund. It's a respectable think tank, respected worldwide. So those are the figures there, and people need to know about that.
Yeah, and part of our problem is like the trusts, they overspend, but they can run a deficit and they make news about it. We can't. The deficit, we hold it personally. We're personally liable as partners.
The deficit is our blood, sweat, and tears.
Yeah.
Holidays, families, health.
Roof over your head.
Absolutely.
And because of that, because it's so close to us, we're very careful with what we spend our money on. And to be honest, we're very efficient.
We're the most efficient part of the NHS.
But now that's
Yep.
being used against us.
Absolutely.
So here's another slide to look at. This, again, it's not news to anybody who understands what's going on in GP, but it's about the falling numbers of qualified GPs. So we know the numbers are falling, and that's partly what's prompted us to do lots of training. We're a training practice, and I'm sure like lots of you, we've ramped up the spaces we offer and try to get more trainees through. We'll talk about the consequences of that in a minute. But our numbers are still falling.
Falling because a lot of the people that we train up are leaving, going abroad, or actually doing something else.
Yeah.
So, yeah, it's not looking great, is it?
And the work and the demand keeps going up. So the number of patients who are being registered with us is increasing. We're seeing substantially more patients registering with each practice. And then if you look at this is very bleak. The number of patients per practice has gone up significantly. And then if you look at the number of practices, that's dropped. And it's still dropping. Practices are closing, again, because of that very reason. It's too financially risky to run that business. So,
and we've got the ridiculous situation now, and I think it's crept up on us. And at the roadshow, the boiling frog analogy was oft mentioned.
Yeah, you know about that if you stick a frog in hot boiling water, they'll jump out. But if you put them in like water that's good for them, but slowly turn the temperature up, they don't realize because it's so gradual.
And they become acclimatized.
They die, they boil to death.
And that's what's slowly happening to us. So we are now responsible, each full-time equivalent GP is now responsible for, on average, 2,295 patients. To just think about that, that's an awful lot. There's only so much more that we can do. We are efficient, we're good, but things are getting out of hand, becoming dangerous now.
Yeah. I think this just describes what we're feeling. Puts numbers to it. So this is another slide that talked about what we're doing. You know, in the whole NHS system, the only people who have increased the number of appointments and services we offer from what was happening pre-pandemic is primary care.
Absolutely.
Lots of trusts and NHS just haven't even been able to reach pre-pandemic levels of activity. You know, we've had 1 million extra appointments per month delivered in primary care.
So was it mentioned at the roadshow as well? We're seeing the entire population of the UK every 2 months?
Yeah.
Something like that?
Yeah. I think the population is sicker post-pandemic. I think they're finding it harder to get help and resources. So we are seeing more sickness. And guess what? You know, we've got 7.7 million on waiting lists. Not our waiting list.
Secondary care waiting lists. And who's looking after them?
It's you.
Absolutely.
And guess what? We're burning out.
Yeah. We're just setting the scene because we just need to explain why we've done this and why perhaps other people should start to look at it as well. And, you know, we've got this situation now where we've had unfunded pay rises for our staff. By that I mean the government says, yes, we'll give salaried GPs and nurses a percentage increase, but they haven't actually passed that money through to the surgeries to give to those staff, so with the result that we've had to fund a lot of the increases from our own pockets, and that can only happen a number of times. We can't really do any more. If that happens again, people's businesses, people's practices will close. It's as simple as that.
Yeah. Yeah, and you know, this is just one of the other costs that we've had to absorb. You know, like everybody else, our heating costs, lighting, consumables, everything's gone up. We are a small business. We have one main customer, the NHS. The NHS has not significantly increased what they pay us. So that stayed the same. Our costs have gone up and they keep going up.
So supplier costs, energy costs, staffing costs, costs due to regulation, all of that is increasing. They ask us to do more and more and more, but actually don't increase the budgets.
And you know, let's be honest, we have done more.
We've done incredibly.
GP practices have gone above and beyond, and they are straining and struggling to help because, you know, GPs care. We actually care about our patients, and it matters to us how they're looked after. And this is being used against.
And this isn't virtue signalling that a lot of politicians go on about, you know, what's about the patients. We actually genuinely care for our patients.
Yeah.
And I can honestly say, hand on heart, all of my colleagues that I work with, they genuinely give a damn about their patients. So that's why we're doing this. And this is why we've gone the extra mile. We've squeezed out every last drop of effort and energy to get the country through the pandemic and to keep services online for our patients. But there's only so much we can do without our own health and without our own colleagues falling down and dropping. And unfortunately, we continue to lose our colleagues on a daily basis.
Yeah,
it's
and
a
that's
sobering thought.
You know, 500 practices have closed since 2013, and there'll be one not very far from you that will have closed or will be considering it.
So this is we're heading towards NHS dentistry level of service. That's what we're heading for. I think people need to know that. You all know how NHS dentistry was gradually underfunded, and now actually there's no option but to go private in some areas.
Yeah.
Because not the dentist's fault, it's just NHS services need to be funded. If they're not funded, the services close.
And then, I mean, this is an awful headline, but it shows kind of the other problem that's happening is we've got all these doctors who are training up to be GPs.
How is it that in 2024 people are waiting to see GPs?
Yes.
And GPs, new, fresh, qualified GPs, are unable to get jobs?
Is it amazing incompetence?
What
is it?
Micro mismanagement of the NHS.
Yeah.
We're given funding in the form of Rs rolls. Everyone look at Rs rolls for people who aren't medics. So there's money that does come into primary care, but the people that make the rules say you can only fund it, you can only spend that money on these roles, and you're certainly not able to spend it on employing more GPs or more nurses. So that's what's got us to this situation.
I think you can use it for nurses,
Can
but
you?
you
Okay,
definitely
sorry.
can't use it with specific types. But you can't use it for employing a GP. And we've got all these GPs who we've bought from all over these countries, we've helped train, who have worked really hard, because it's not easy to pass those exams. And they're getting there. And you know what? They can't find jobs. And it's not that people don't need GPs. Look at the situation. You couldn't make it up if you tried.
It's almost, you'd have to try hard to do this. It's not by mistake.
Yeah.
So we went to the road show, and at the BMA road show, we were given a kind of menu of things that we could look towards doing to make sure that we preserve the services that we've got right now for our patients. It's the GPs are on the side of the patients. That's the first message to get across here.
Yeah. So we need to look after our patients. We need to make sure that there is still a GP service for them to access, for them to help. Let's be honest, it's bloody impossible to access the rest of the NHS at the moment. We're the easiest service. I'm not saying we're very easy to access, but compared to the rest of the service, we're the ones who are doing it. So there's lots of things that you can do.
And today we're talking about the BMA Safe Working Guidance. So this isn't anything new. This was released many years ago, and it's a European thing as well. So throughout Europe, it's recognised that the safe number of patients that primary care physicians should be seeing as a maximum is 25. And let's see how we can do that safely, so we can preserve safe, effective primary care in a very stressed and under pressure system.
So the hospitals run waiting lists. We certainly know about that. They run waiting lists that sometimes we seem to be managing, because I'm getting requests every day. Can I have an expedite letter? Because I called the hospital and told them I'm feeling worse, and they said, well, get your GP to write us a letter, because the bit in brackets is, we don't believe what you're saying to us, but if you say the same thing to your GP, then it gives it an element of truth. Oh no, we don't even have time to talk about that.
There's lots of stuff that's being bounced back from secondary care. Again, not the secondary care colleagues' fault, it's just the system.
Yes.
But the thing is, the system is pushing all the work and the stress and the pressure onto what they consider to be an infinite resource, which is primary care.
Yeah.
So, when it gets busy during certain winters in A&E, they declare an alert.
Yeah, they say, right, we've got to close our doors, and we will now be directing all traffic.
So how many patients do you think are seen in A&E, in our local A&E?
So, the bigger hospital in
Towards Manchester.
Yeah, towards Manchester. I don't know, how many do they see? 2,000 a day?
Nope. Keep going.
5,000 a day.
No, other way. Other way, yes.
Okay, 1,000.
Nope.
800.
Nope. Keep going. Half that.
400.
400 patients a day. On that's a busy inner city type practice. Yeah.
Practice
A&E, yes.
Do they want to come and see one of our Monday, just the mornings?
On a Monday morning at our practice, which is for 16,000 patients, we can have up to 400 requests just in the morning in the first couple of hours. So
we are seeing 91% of the stuff.
Absolutely. So, we need to kind of put it all into context and actually now start to stick up for primary care and say, actually, look, we can't carry on doing these kind of numbers. It is unsafe. Our patients deserve better.
Yes, they do. They do. And
this is infuriating. We get these letters sometimes from the system, as they call it, telling us that secondary care is under great pressure and reconsider referring patients, as if we refer patients to the secondary care for fun.
Are you telling me, Dr. Allen, that you don't think, oh, today I shall send extra patients to a hospital because I need something to do?
Again, it just betrays that some people really don't understand how we work. And actually, some of our colleagues in secondary care don't know how we work either. So it's important to get this message out.
I mean, I think that's part of the message is we are a system. And we are very aware of when there's pressures in the secondary care part of it. We're expected to flex. We just want a little bit of the same acknowledgement
I
for
just
us.
want to show you as well, whilst you're on that. This is a typical clinic for the duty doctor on a Monday morning. So there you go. Look at all of that. That's one doctor.
That's
Okay.
actually amazing.
Yeah.
And yeah, if you're
That's
that
in a
doctor,
morning.
if you're that doctor, you're wiped out.
Absolutely. And then you have to do your paperwork, you have to do your path results, you have to deal with all the staffing issues, all the
those
questions,
letters saying, can I have an expedite letter for my
CQC.
hospital waiting list?
all of that.
Yeah.
So, there's only so much, again, that we could do. I'm not going to labour the point too much more, but let's just, try to get this message across. And we do have official safe working guidance, which is from the BMA and endorsed by many organisations across Europe. No more than 25 contacts per day. So how do we do this?
So when initially I saw that, I thought, oh my God, my patients are going to kick off if I say, right, I'm going to see even fewer review, because I thought, right, they want to be seen. But they shared this slide.
And this is
which is
good
interesting,
data,
isn't it?
good
Yeah.
research.
Yeah.
And it shows, look, there's no difference at all. We're talking about, let me just move my face to the top there. Let's just try that. Maybe we'll be able to see it. Yeah. So you've got overall experience as rated by the patient on the y-axis. On the x-axis, you've got the number of appointments per 1,000 patients per month.
Yeah, and it's interesting. Look at the ones who they do 200 appointments per month, and then the other end of the scale, we've got 800. So nearly 3 times as many. And the proportion of people who regard them as good is the same.
Absolutely. So it's not going to lead to meltdown if we
handled
if we
correctly.
protect patients and deliver safer care and protect our staff as well.
Yeah.
And so how do we do it? We've got a RAG rating system that we kind of invented 3 years ago during the height of the pandemic.
Yeah.
Let me just make this slide a little bit clearer. Is that better? There we go. So, and go on, Free, do you want to explain a little bit?
This was kind of what we were talking about after this event, is that we do RAG rating. So we are a total triage practice. Every request for an appointment comes in through triage and is triaged by a senior clinician. And we have developed, we call it the Wilmslow Triage system. It's got red, amber, green ratings, and we've got some tweaking around it. So you risk stratify all the requests that come in. Because look, we've got capacity, but it's limited. But the demand is unlimited.
Ahmed's Law. What's Ahmed's Law?
I don't know. What is Ahmed's Law?
Sorry, demand in a free at the point of delivery healthcare system is unlimited. Don't let anyone tell you otherwise. It's through almost 50 years of primary care experience. People come, people go, people come with their theories, but the one theory that is pretty robust is Ahmed's Law. So there you go.
So I think part of the problem you have is that you've got people who are demanding, and they can sometimes take appointments away from people who require it. They have a clinical need for it. And how do you prioritize urgent cases?
So the reason we did this was during the pandemic, during the really beginning bits of the pandemic, we were getting loads of requests coming through, and it was the people with the sharpest elbows and the loudest voices who were being seen. Our cancer patients, our elderly patients, our genuinely unwell patients were really,
they were put at the bottom of the pile, and often it was too late by the time you realised that had happened to do anything about it. So we set this up, been going for over 3 years now.
It's been shared to dozens and dozens of practices across the country. It does work, it needs tweaking, and it can be customised to any GP practice.
Yeah,
and
all sizes, small and large.
And it doesn't necessarily depend on your triaging software or your digital front door.
Yeah, we use Accurix, but I think you can do the same with other suppliers. So, but we're probably not going to go into that a whole deal now.
No. So this is just an example. Let me just make my face go to the bottom right. Let's try that one.
Okay, so this is how we set up our appointment screens.
There you go.
So this is just an illustration of one. I think this is probably a summer one. So I know as our demands go up in winter or periods of staff illness, the proportion of appointments changes. So most people have 2 telephone appointments. Again,
Most GPs.
Yeah, most GPs. Then we have the routine green. We have ambers, and then we have reds. So reds are for urgent slots. They have to be seen that session. You know, the person who's come in and you think, right, they have a chest infection, they do need to be seen, or like a child, you know, a baby that is unwell. Or
So using this system, you're going to make sure that those patients that really need to be seen that day are seen, and dangerous clinical scenarios aren't slipping through the net. We've still got to catch all of those. We still care. We need to make sure that we look out for those patients. The ambers are also urgent, but they can wait.
So they could do wait days or weeks. And again, in our system, it depends on what the demand is like.
Yeah.
So I know when we're busier, there's a slightly longer wait for those, but like sometimes when it's easier.
Yeah. And the greens are the ones that, you know, a clinical triager, an experienced GP has assessed properly and has deemed that they can wait. Now, obviously, that can change, and patients are always told if things worsen, they can be seen. But that's the way that we're doing it. And the proportion of greens to ambers and reds are constantly tweaked. They need to be tweaked according to your own particular practice's circumstances, to the time of the year, if there's a bank holiday, all of those things.
School holidays,
So this, I feel, is how we can meet some of the suggestions from the BMA Roadshow, in particular the safe working guidance. How can we make our appointment system safer for patients and for clinicians, and make sure that the urgent cases are seen appropriately?
So we're not going to go into this in major detail, but if you just Google the Wilmslow Triage system, you can get a full explanation about it. We are doing some free workshops around this with Accurix, so I think if you Google that, you'll find those as well. We've shared loads of resources about this. We are not gatekeeping this at all. It is free.
Get it out there, try it, use it, see if it works, feedback. And hopefully, you know, primary care will last next winter, which is going to be very tricky. So there you have it. Our particular way of trying to run a safe waiting list for primary care. If we all do it, if all the practices around us do it, if all the practices in England do it, if all the practices in the UK do it, we will make sure that our patients continue to get a safe service, and we also make sure that our colleagues, our staff, and everyone else who's working in primary care, which is close to collapse, that they also remain safe. It's so important to look after your colleagues. Safety first. Put your mask on first before you're safe to see others.
Yes, and remember, this system, we've talked about how we've used it for our total online digital triage. If you do triage in other ways, telephone and other ways, you can still use it to run a green list of people and conditions that are okay to wait until the next routine appointment. Use it, keep your practice safe for your patients, because nobody else is looking out for us. We need to look after ourselves. It's the truth. Who is looking out for us? Tell me. I've not been impressed.
You're not allowed to say anything during PERDA, apparently. Apparently we're not supposed to have opinions during PERDA.
I wish somebody would understand the problems we face and do something about it. You know, like a...
Do you feel a rant coming on? Yeah. Okay.